Eliminating unnecessary medical tests and procedures can be as important in delivering high-quality care as providing the right interventions. Learn how one major health system is taking a hard look at its treatment protocols, thereby improving quality outcomes and decreasing healthcare costs. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Petterly, senior writer in AHA's Washington office, and your podcast host. In this podcast, part of the Members in Action podcast series, Joan Risner learns more about the work of the High Value Care Committee at Johns Hopkins.
Hello, my name is Joan Risner, Director of Member Relations at the American Hospital Association. This podcast series is part of the Value Initiative, which highlights steps hospitals are taking to improve affordability and value for their patients and communities. These members have implemented strategies that enhance the patient experience, improve quality, or lower costs. In this Members in Action podcast, we will focus on Johns Hopkins Health System's High Value Care Committee, an initiative created to increase the value of care the patients receive. Joining me to talk about this program is Pamela Johnson, Vice Chair of Quality, Safety, and Value in the Department of Radiology and a physician lead on the committee. Dr. Johnson, thank you for joining us today.
Well, thank you so much for inviting me.
Well, let's go ahead and jump right in. Tell me a little bit more about the High Value Care Committee, how it started, and what it is and what it does.
So the Health System High Value Care Committee is directed by myself, 3 hospitalists, and a pathologist, and it really was a number of different initiatives that led to the creation of this committee in 2016, much of which began as grassroots efforts. So in 2009, one of our cardiologists at Bayview Medical Center, a group there, formed something called the Providers for Responsible Ordering. They felt very compelled to eliminate unnecessary tests that did not add value to patient care and only added cost, and they began working with CKMB. It was one of the most widely used lab tests for acute coronary syndrome in the emergency department. And they created this alliance and engaged some other institutions and were very successful in their initial work. And that sort of was the initial spark. And then the Graduate Medical Education Committee thought it was very important that our trainees became involved in this. And that's where I got my introduction in about 2015 as one of the residency program directors. And at the same time, in the Department of Medicine, 2 hospitalists created a committee to evaluate all of the tests and treatments that they were delivering, and were they really improving patient care, or were we simply practicing in the way that we had been trained and without considering being more judicious based on evidence that has evolved since we trained many years ago. And so as a result of all of these efforts, we began working together. We were collaborating across departments, radiology, internal medicine. And in 2016, the leadership of the institution was very enthusiastic about our work and wanted to basically empower us to do more. And so they created this committee and resourced us with data analysts, value analytics, project management, and really escalated the work to the next level with the ambition of taking great projects that were being done locally, as I mentioned, vetting them, evaluating them for safety outcomes, and then advancing the best of them across the whole health system. So we have 6 hospitals and a large community practice. And that's how the committee was created in 2016, and we've done a number of different projects since the inception, and it's just been really very rewarding and exciting work for us.
Can you talk a little bit about some of the interventions that you've studied, some of the treatments, or
Certainly.
Or go ahead.
So as a radiologist, one of the reasons that I became involved in this work is that I interpret studies and I understand the cost and the radiation exposure, and I feel very strongly that I want to be sure that patients only undergo imaging that adds value and that our interpretations also best guide the management, the downstream management for patients. And so in 2016, we created a strategic plan to ensure the appropriateness of all of the imaging that we perform, and we looked at a number of different ways of analyzing the imaging that we were performing at Hopkins, were there areas of overuse or what we considered unnecessary use. And then we created broad campaigns that involved education, clinical decision support, consultation services, and provider feedback reports to try to reduce imaging in some areas where I think many other institutions are also focusing. So on the imaging side, it was lumbar spine MRI for complicated low back pain, abdominal CT with and without IV contrast, which is a higher cost, higher radiation exam. The American College of Radiology is very supportive, or has been campaigning to reduce unnecessary thyroid ultrasounds and biopsies, which can precipitate unnecessary thyroidectomies. And so that's sort of a long continuum where the radiologist is the person who can initially create this path that we might not necessarily want to go down for a patient who has a benign process. And others that we've identified, like on the inpatient side, we see patients getting ultrasound after they'd had a CT, and we know that doesn't really add additional information in many cases. So those were the imaging tests. On the lab side, the Department of Medicine High Value Care Committee had worked on reducing folic acid. When we were in medical school, we were trained to order that on every single patient we admitted, and it just does not add value. So that was one of the early ones. C. difficile testing, which actually carries risk because false positive diagnoses, which result in patients getting unnecessary antibiotics. Many of these tests do carry risks if there's a false positive, or in an imaging exam, if there's an incidental finding that then precipitates a big workup just to prove that something is benign. So it's not just the test itself, it's the consequences of the test. And then the CKMB, which I mentioned, which is the cardiac biomarker, we made sure that all of our hospitals stopped using that, as there's a better test, troponin, and it's just the CKMB is not adding any useful diagnostic information in those patients. So those are the tests that we went after. And the CKMB work was actually published, and they showed that in 1 year they reduced charges by over $1 million. And they actually increased their ability to diagnose acute coronary syndrome. So that's one of the things that we feel is very important about the work that we're doing, is to ensure that outcomes are maintained or improved and that there are no unanticipated consequences by reducing use. So we follow evidence-based guidelines, and many of the clinical practice guidelines, like the CKMB, is one of the American College of Cardiology's clinical practice guidelines, has been saying for years now that CKMB is unnecessary and that troponin is the test of choice. And yet we still have hospitals across the country that are using this test. And so, we want to be sure that it's safe, that it's evidence-based. So that's an example of the kinds of cost savings that you can see from a single lab test. One of the big initiatives that was undertaken by Steve Frank, one of our anesthesiologists, was to reduce unnecessary transfusions, and he's been working on this since 2014. And there's a lot of evidence to show if you reduce transfusions, you actually improve outcomes, that transfusions carry risk. And another thing that we were trained in medical school was that any time a patient's hemoglobin dropped to the point where you needed to transfuse them, you just gave 2 units of blood. But this is no longer the teaching for best practice. The best practice teaching now is to give 1 unit and observe patients who are hemodynamically stable. They've also changed the threshold at which you're supposed to administer transfusions, recognizing that patients can tolerate anemia better than we knew back when I trained. And so that's the American Academy Clinical Practice Guidelines, evidence-based guidelines. And I think that there's a big challenge from going from evidence-based guidelines to practice. It's changing practice patterns. It's getting the information out there that there's new evidence that's better, that's safer. But the transfusion project is probably one of the best value improvement projects that any institution can do. One, because it actually improves patient outcomes. It improves safety and quality of care if you follow the clinical practice guidelines. And it is a tremendous cost transfusion. So the work that was done at Hopkins by Steve Frank reduced costs for the health system by more than $2 million a year. Additionally, if we avoid giving transfusions where they're not needed, we increase the blood availability for patients who really do need more than one transfusion and are having serious bleeding. So I consider those are two really great projects that improve quality safety, strongly evidence-based. I have shared these two publications with you on those topics that others may be interested in reading.
I know you do have some fabulous data on outcomes, and yet when you think about the impact on patients, can you think of an example or two where, you know, you had one of those aha moments when you thought, wow, we're doing this better than we used to? Any specific examples that come to mind?
I think one thing that when people think about value, they're thinking about targeting overuse, and we really look at it more as improving appropriate use. So where we should be using tests that we haven't been using enough of in the past, or even innovating to develop new tests. So I can give you two examples there. And one is that in our emergency department, we have our emergency department champion these guidelines that they put into the electronic medical record, beginning with chest pain. They found that by increasing use of coronary CTA in the emergency department, they reduced the number of patients who were admitted who didn't really have coronary syndrome. So that's been an interesting discovery process for us, where the increased use of an imaging test protects a patient from a much more risky and expensive element of care delivery, which would be an admission when they didn't really have a coronary problem. And chest pain is, it's a challenging diagnostic process, but by following the evidence-based guidelines, we ended up improving care in ways that was better than we had expected. So I think that that's one area where we have also learned that rather than just targeting overuse, we want to build out these decision tree guidelines that guide providers along the spectrum of care, from labs to imaging to treatment to medications. And that's one of the things that we've been working on lately. And I think in terms of innovation, where innovation can improve our ability in diagnosis, I'd like to talk about how our urology and radiology departments were working together on evaluating benign and malignant renal tumors. And there's been this decade-long conundrum where we cannot distinguish benign and malignant renal cell cancers from benign oncocytomas. It's not an uncommon tumor. And they got together, and I think it's really testament to the power of cross-departmental collaboration. And they realized that there was an inexpensive nuclear medicine test that would target mitochondria, which are in the benign tumor. They started a research investigation and discovered that they could distinguish the benign from the malignant tumors in 99% of cases. And there are patients that, as a result of this, had to have their kidney removed, and some who even would have had to go on dialysis, who underwent this inexpensive nuclear medicine test, discovered that their tumor was benign, and then were spared and protected from an unnecessary surgery. So that's where I see imaging bringing real value, and I think is a really exciting part of imaging. We're not just targeting the underuse. We're looking at ways that imaging improves care outcomes and reduces costs in a bigger way, and reduces burden on patients, because we don't want them to be admitted unnecessarily. We don't want them to have to go to the emergency department unnecessarily. And it's one area where imaging actually reduces those types of situations.
That's fabulous. You've really had wonderful outcome measures and impact on patients. When you think about lessons learned and either things that, if you had to do it all over again, you would set up the committee's work in the same way, or other lessons that you learned along the way that you would advise others to consider, what thoughts come to mind along those lines?
The most important lesson that I learned very quickly as a radiologist, trying to reach out to people that were ordering things in my department, there has got to be a team approach. And from the very beginning, if you want to implement an imaging appropriateness improvement campaign, you've got to first reach out and partner with the emergency department, the internal medicine teams, inpatient, outpatient, and put together a committee that works together and also discusses the different appropriate use criteria that each specialty has, because the American College of Cardiology, the American College of Physicians, and the American College of Radiology all have best practice guidelines for clinical conditions, but they may vary slightly. And teams have to work together. So for another example is when we decided to try and reduce unnecessary thyroid ultrasounds, we sat down with the endocrinologists and pulled together their guidelines from the American Thyroid Association and ours from the American College of Radiology, and did these in consensus so that everybody agrees that any change we're going to make in practice is going to be deemed, higher quality and safety by all physicians involved in the care of that patient. So I think that's one of the most important things that I've learned, and it's been incredibly rewarding because I've developed relationships with colleagues that I hadn't worked with before, and we're all working for the same goal, and that is to improve the quality of care for patients and protect them from tests, treatments, procedures that they don't need. And so you'll discover that everybody wants the same outcome, but we all have to work together and make sure that different disciplines know is all synergized and integrated in a way that's best for the patient.
When you think to the future, is there anything that's on your wish list or any way that you see the role of the committee changing or expanding in any way?
Yes, well, that's a good question because I got my wish list. I got my holiday gift for where we wanted to go in the future. And we spent 2 years identifying overused and underused, doing individually targeted projects. And then our emergency department independently developed 70 best practice guidelines for how they manage every condition that comes into the emergency department. They put it in the electronic medical record, and it's a really fantastic resource. And they engaged the house staff in development, and it's physicians and nurses and advanced practice providers all working together to create these guidelines that direct best practice and improve efficiency, and it's just been fabulous. So we applied to the leadership and got the funding and resources to take these guidelines and send them across the entire Johns Hopkins Health system. And what we want to do is, rather than thinking of things from a cost perspective, we're going to be thinking of it from a best practice evidence-based perspective. And rather than putting alerts in the electronic medical record to tell people that you shouldn't do this or you shouldn't do that, we're going to put guidelines in the electronic medical record that say that this is the evidence-based best practice management for gastrointestinal bleeding, for diagnosis of pulmonary embolism, everything from designed around a clinical condition from the beginning where you're trying to make the diagnosis to how you manage it. And it's just a tremendously exciting project. We're looking forward to it. We have teams all over the institution that are going to be working together on this. And I think that is really the way that we need to proceed, because it's got to be the best care that we can deliver is the care that's driven by the evidence in the literature.
Well, it certainly does sound as though the High Value Care Committee is having a significant and positive impact at Johns Hopkins, and I want to thank you, Dr. Johnson, for joining us today and sharing more information about this important program. It truly is an excellent example of improving quality and patient outcomes to decrease cost, improve quality, and improve the patient experience.
Well, thank you so much for inviting me.
For more podcasts and additional tools, please visit the Value Initiative's website at aha.org/The Value Initiative. This concludes our discussion today. Thank you for listening.